Welcome to episode 21 of Future Proof PT. After 20 episodes exploring what value means in physical therapy and how PTs can partner in value-based care models, we're often asked one crucial question. Why should I care about this today? If you're not in a risk-bearing contract, or if your clinic operates strictly in fee-for-service, if your team is already stretched thin, really, what's the tangible incentive to learn about value-based care right now? Today's guests have an answer for you. It's not a theoretical one, but one they've lived. Cody Lee and Jonathan Smith are here today. They've taken the concepts we discuss on this podcast and translated them into real practice. They've built provider relationships, they've increased referrals, they've grown their teams and demonstrated value all before any kind of formal risk-based arrangement. They'll share a powerful decision-making framework. When you're unhappy with the status quo, you can accept it, change it, or leave it, but you have to pick one. They chose change, even without a playbook to follow. This conversation is about the bridge between theory and practice. It's about immediate benefits rather than just future promises, and about why understanding value-based care helps you win today and not just prepare for tomorrow. So let me introduce our guests. Cody Lee is a physical therapist at Southeast Health in Alabama, focused on improving musculoskeletal care through stronger partnerships with primary care and the system ACO. He has a unique mix of clinical experience and operational insight from 7 years in the health system. Cody's passionate about advancing the role of physical therapy in value-based care. And then Jonathan Smith, who is the clinic manager at Southeast Health in Alabama. He started in the field of physical therapy in 2015 as a PTA, and then he went on to get his DPT and then to become the clinic manager. He's passionate about relationships and how they can elevate an entire idea and profession when unified. So without further ado, let's welcome our guests. We have 4 people on the podcast today. We have spent 20 episodes of Future Proof PT talking and conveying in various ways what that word value is and can be in physical therapy, and then how PTs can partner already in value-based care models that are out there. So we're trying to convey that the path to value-based care is not a straight line. It's very windy, and there's not necessarily a prescription for how to do it. But what we do want to make sure we convey, and I think it'll come out when you hear the stories that our guests are going to bring on today, that value-based care is really about communication, it's about connection, and it's about interdisciplinary and patient-provider collaboration. And frankly, PTs are some of the best at it of all of healthcare providers. So you're going to hear stories today from 2 PTs who are really working on the ground in patient care, who want to provide the best care to patients. And they've learned from listening to and from reading things that we and others have talked about and written, done their own research, found ways to apply concepts to their everyday interactions. And so we wanted to bring them on here to share a bit about their journey, partnering with other providers. What's it like? What can other therapists relate to? So we're super excited for this episode 21.
Amen to that. And thank you, Dana and Jonathan and Cody. Thank you for being part of this process. So absolutely true. It is a pleasure to have you guys here. And it is an absolute pleasure to actually have 2 individuals that are making things happen instead of just theorizing, which is what I'm and Dana sometimes are guilty of, is that we have that large overarching narrative of what, but very few of us actually have the how, and you guys are doing the how. You're doing the hard work. So I think it's really important for the listeners and for just the general PT community to understand that a bootstrap effort does result in actionable change, and you guys are the agents of that change. So without any further ado, I will kick it to Cody to explain some of the efforts, and then he will go with Jonathan and describe all of the things that have been done. So go ahead, guys.
Yeah, thanks, Alex. And thanks, Dana, for having me back and having Jonathan on today and getting to talk about this topic and a little more of kind of what we've tried to implement and apply from a lot of what we've learned from y'all. And then, like you said, kind of further research we've done in that area. So for me, I originally started kind of learning about value-based care. And like I heard the term ACO when our previous clinic manager, and I should probably say Jonathan is my clinic manager now. So we work together. Both of our previous managers, his name was Chris. He actually was promoted and hired as the ACO director for our local health system. And so that's when we kind of heard that first word, and I had no idea really what that meant or what it was or what they did. So just getting connected with him and kind of talking to him a little more about what they do was helpful. And so stayed, connected through that relationship. And then I think it was right after I graduated, I went and met with him just to learn a little more from his standpoint of, how's it's been since he's been in that role, and what does success look like for them? What are the metrics they're tracking, just to get a better idea of what all that looked like. I found Dana's work originally through Timeless Autonomy through LinkedIn, and I think I read that for about a year before I actually connected with Dana. And that's really where like the value-based care and ACO knowledge really came from, was reading that and then just finding resources from what you shared, and then eventually sharing that with Jonathan, and then starting more of a collaboration with Chris and their team, and seeing how we could help. But yeah, I think that's kind of been the basic journey so far, just overview, and Jonathan's got a few more stories he can probably share from that standpoint.
Yeah, so I remember for me, like our joke between each other is Cody's like the data guy. I don't care for that as much, but I like the relational stuff and the networking, and not so much like whose number do you have in your phone, but because of two people and connecting them together, like the greater mission or what happens from that is something I'm passionate about. So for me, a lot of this started just as a staff PT reaching out to, because we're in a health system, there's a lot of opportunity for collaboration and jumping in with other providers. So I remember meeting with we have a resident run clinic here. And so I just reached out to the two physicians that led that. And they're like, yeah, come and sit down and we'll chat. And so we sit down, and I was kind of thinking I was going to ask them questions about what they did. And it turned into them interviewing me about like, so what even is PT? And so we had a lot of conversation with that, which was pretty cool. And both of them since have gone on to other roles, but both of them referred to us quite a bit after that conversation. But one in particular went to another practice that was actually external of our organization. And she and I kept in touch. And we just kind of grew that from there. And we got some like cool stories going along that. But the cool part was when Cody brought this value-based care stuff to me. And I'll be honest, when Chris that he mentioned went into his role, I was like, I mean, that sounds cool, but I have no idea what any of that means. Like, and he explained it multiple times, and I still was like, yeah, I still don't understand. But Cody has a cool way of being able to synthesize information and data and put it in like an actionable way. So I remember he and I having some conversations about it, and me kind of thinking like, well, wait a minute, like all these networks and these relationships, like we can start leveraging those to actually get something done. Because I think we just learned that nobody really understood how PT fit into that BBC picture by and large. And so being able to go explain, hey, now I understand, here are the things that you care about as a provider, and here's how I can come alongside you as a teammate and help you with some of those. So it's some cool stories, I think, that developed from there, but really started with Cody just being willing to figure out who were the players in the game and who needed to know what. I think he and I, for a long time, for many years, have gotten information from somewhere and felt like, well, hey, Cody needs to know this, or Jonathan needs to know this. So really credit to him for just bringing that up to start with.
So there's an interesting point where, like in I think Einstein's quote that in theory and practice are the same, but in practice they're not, right? So we can talk about all of these hypotheticals, but the reality is the practice makes perfect. And Cody, I'll have a question for you. So you were mentioning data, and you are the data person. What kind of data do you present to these organizations? How do you package this data? How was the data received? How was it interpreted?
So it wasn't even really us presenting data. It was more of starting a conversation of learning what metrics matter to them. So we needed to have a better understanding of how we could kind of impact what they care about. So there are a ton of quality measures, but some of the big ones would be like readmissions, total cost of care. They're in a Medicare shared savings program. So their goal was to, share savings from their previous couple of years of taking care of their population. So having that understanding just mattered for us to have a better idea of what we can impact. And then it started just conversation of, what does the MSK population look like from ED standpoint? So going to the emergency department. So asking, were there any like avoidable ED visits that were kind of, low back pain related or some musculoskeletal pain related. So getting an idea there of what that looked like for them. And then just looking a little more to the overall utilization. So I would say we don't do a great job from like an outcome measure standpoint. I know y'all talk about that a lot, and tracking data kind of longitudinally and that stuff. I think we're trying to figure out how to do better. But it was understanding where our benchmark was compared to everyone else in our area. So I think we like to think we're good at, treating low back pain or musculoskeletal pain in general. Does the data actually show that? from, a claims perspective, events perspective, as in visits and that sort of thing. So that gave us a better idea when we were able to look at that. And Chris was generous with being able to allow us to see some of that data. And that comes with having built relationships with him over the past several years of him being our manager. And then I think him trusting both me and Jonathan with that sort of thing. So it was getting an idea of where we stood, I think, from a musculoskeletal perspective and understanding what we could impact. I think going forward, we plan to look a little more as far as maybe specific diagnoses, percentage of utilization, I would say, of how many are actually going to PT. And something Mark Gruner recently said on the podcast that kind of sparked my curiosity was talking about NEOA and the narrative that a referring provider might give to a patient and how that narrative could essentially affect, whether they follow through on PT or not. So even looking at how many of their patients are referred to PT and then how many actually go to PT, and is that an area of improvement they could see if they were to maybe change their narrative. So that's kind of a longer term view, I think, with some of that stuff. But I don't know if that answers the question exactly, but that's kind of how we're looking at some of that right now, Alex.
Right on.
So what you're referring to from Mark Gruner was he was talking about how a lot of times just primary care docs don't have enough time to engage with their patient in your typical fee-for-service environment. They're saying you have low back pain, you should go to PT. It takes more than that. A lot of people need more engagement as to the why. They need to feel like they're being heard and that physician as a PCP really understands why they might need PT versus patient just thinking, well, I can just go to ortho. They're not taking this seriously. That's nice PT, but I don't want to do that kind of a thing. So I love that example that Mark brought up and that resonated with you. The one other thing to call out when Cody was talking about how we're doing compared to the region, when a value-based care organization is trying to manage a patient's cost and quality of care over the whole year, the way that the payer, so in this case in the Medicare Shared Savings Program, it's CMS, Center for Medicare, the way they're looking at, well, did you do a good job or not? It's not subjective. It is a formula. And you can read about this formula if you just Google Medicare Shared Savings Program, and I can link that in the show notes after this. But what they're looking at is a combination of how, let's just bring it to the individual patient level, although we look at this for the whole population that a physician group is managing. How did the region do during the same time period for a typical patient that looks like that patient and for a population that looks that way? How did the region perform in managing a patient like that? And then how did that group historically perform? So the benchmarks are made up of historical spend versus present spend, regional spend versus our own spend. And then there's also a national component to a lot of the benchmarks in these programs where they say, we are going to try to project the national spend over the course of the next couple of years. And we're going to build that projection about the national spend, the anticipated spend, into that benchmark. So again, it's historical and regional, and then there is some component of a forward-looking estimate of the national spend. These things are blended together, and then they're going to compare how did you do this year versus the benchmark that we created based upon this algorithm of historical, regional, and national spend. Just to clarify that, because these things, they do seem like, right, they're up in the clouds. What do we mean by this? There is a very specific formula that's used, and it's tweaked over time.
So I do have a question for Jonathan too. And since you were mentioning more of a relationship building and communication with physician and groups, how do you present your own discipline as physical therapy? And how much education did you have to do to both show your discipline's clinical competency, but also to show that path dependence, that you're trying to create a new entry point into the health system, and that your discipline, your trade has the capacity to handle some of these orthopedic cases?
Yeah, good question. So I think that's what people view as the hardest part. It seems from the folks I've talked to is this fear of like, well, I don't know what to go say to this physician or this nurse practitioner, or this PA. Like, what am I supposed to tell them? And I think we have to keep in mind that it's not their fault, but they're not taught at any point what we do. And so they're clueless as to how we can help them. And it's our job to go teach them that. We can't just, like, if you're waiting on that physician to come to you and say, hey, I just learned everything about PT and how you guys are experts in MSK care, like, that's never going to happen. And I think we have to wake up to that and take some ownership of going and be evangelists for our profession. So I think just approaching it from number one, I think that's this podcast and talking with Cody and talking with Chris has been so helpful, because you start learning like the buzzwords and the things they care about, because you can go in and say, hey, we're really good at treating low back pain and this patient got better pretty quick. But that doesn't really mean anything to them. But if you can say, hey, we've got some opportunity, it seems like, you know, you don't have a lot of time to spend with a patient. And I'm fortunate to be able to spend an hour at a time with the patients that you send to me, so we can work on things like behavior change. And then on top of that, like, if we can get some behavior change, then what we're trying to do is reduce downstream, you know, things like medication needs and these lifestyle changes that are important. And if they come to us first, we have a lot of data to show that they might not need imaging and they might not need injections and they might not have to see the specialist. But then the other cool part is, you know, not throwing any shade on our ortho friends, they want to see people they can operate on. Like, they don't want to see the ankle sprain and they don't want to see the acute back strain, because there's not much for them to do with that. So instead of clogging the system up with every patient going there first and then some getting bounced back to us, let us be the hub and we can help you decide where they should go from there. And I think that was the sort of the wake up call with the physician friend that's now the one I met with initially, which turns out she's now the chairwoman of the ACO. Pretty great happenstance there. So a lot of times, like, I hear things of, here's, you know, APTA reported this, and I'll just ask her, like, hey, from your side, does this track? And one recently was talking about how physicians just don't feel prepared or like they have what they need to Dana's point, kind of make the argument for PT. Like, here's why you should go. And I remember asking her, like, do you ever feel like you're, especially before we started chatting more, like painted in a corner where you've got to be a physician and an expert on PT? Like, you've all of a sudden got to know everything that we do to convince a patient to go. And she was like, yes, that's the hardest part of getting the buy-in. But because of having conversations and talking about where are we experts, and more importantly, where are we not experts, she feels comfortable saying, like, no, let me explain how PT is going to help. Like, here's the expectation going in. And then we all know if a patient comes in thinking this is going to help, it's probably going to help. Like, I don't even have to be as good if you already think I'm going to help you coming in. So it just sets everybody up for success. So I think to answer your question on the relationship side, it's like, if you can just go explain how I'm going to be your teammate and your partner, like, I'm not trying to convince you PT's helpful. I'm trying to help you solve the problems that I know exist because I took the time to learn what your problem.
APTA ran a report about the primary care practitioners' perception of physical therapy December last year. And so this was a large, robust report that tracked that perception over 17 years. And 95% of PCPs had a favorable view of physical therapy. They appreciated our competence, and 88% stated that they trust clinical judgment. But if you looked into the referral patterns, what drove referrals from PCP to PT were much more relational, what you were describing, Jonathan, which is the PT's competence, experience, and reputation, the PT's willingness to collaborate, and prior patients' satisfaction with physical therapy, which has nothing to do with objective competence, right? Because satisfaction doesn't always drive competence. So this would be a question for both Dana and Cody. How do you still pivot and change the subjective relational component of PCP to PT handoff into more of an objective data-driven handoff, that the ability to use data to stratify risk, to identify the optimal point of entry into the clinical system, and to say that PT is optimized for this patient, but maybe not this, versus this patient has multiple comorbidities, that has complex psychosocial narrative. They may need a more specialist approach. So Cody, what do you think is the best way to use this large data to create more objective handoff points from PCP to PT?
That's a great question. The risk stratification part, I don't know if I have much experience from that standpoint. I mean, I think in general, it's like Jonathan talked about, one kind of educating a little bit more of what it is we can help, especially like the local physicians, whether that's in the ACO or just other providers in the area we could help with. I mean, I think any kind of acute musculoskeletal pain, you can kind of pretty much come to PT and will likely be able to help. But I think from my standpoint, I would need to look better at kind of what our data is currently as a clinic. And like I said earlier, that's not something we've really tracked super well as far as outcome measures. A little bit just being difficult to track within the EHR and having to kind of build things on our own and ask our reporting teams and all of that as well. So I don't know if I have a great answer, honestly, for that. Alex. I'm going to see if Dana does instead.
What you need at the most basic level to be able to manage a population, or to what Alex was bringing up, right? Figure out who should I attempt to reach out to and when, right? Who are the right patients? I have 10,000, let's say I have 10,000 or 20,000 patients that are attributed to all of these physicians, right? And attribution just means if we look back at the claims data in the past, which patient matches with which physician. And if a patient has been predominantly seeing the physicians that are in our ACO, then that patient is part of our ACO. They're attributed to the ACO. That's kind of the basic how that works. And then the ACO, when you join an ACO, right, they're giving you all of the claims data. Every month or every 3 months, you're getting these sandbox of data, and then that data has to then be analyzed to look at things like trends. So you can pull out from the claims data patients that have had a diagnosis, one of the diagnoses of low back pain, for example, if we stick with that diagnosis, and then you can combine that with low back pain plus ED utilization, and then stratify, looking at the whole population. A lot of times you're working with an analytics team or maybe a vendor that's helping you analyze the data. And you can stratify that data and say, let's first look at who's had low back pain and ED utilization and hospitalizations. And then maybe you just look at ED utilization. Or you look at someone who's had low back pain and had physical therapy claims. And maybe those claims are outside of your system, right? So you're looking at that. The benefit and what you really have to layer with that claims data, which is just data. It's just going to tell you diagnosis. It's going to tell you the physician or the provider that was involved. And then what you're going to do is you're going to look at that patient. And if they've been in your system and you have access to the EMRs, then you can, in the best scenario, you're looking at that patient presently, you're looking at their care journey. So if you go into, let's say you're using Epic, you can go into their medical record and go back and take a look at some of what they have been experiencing in the system lately. Go right into their chart, right? And then just look at what has been happening. It's kind of that simple. So if we look in the claims and we see they have low back pain and they have been in the ER, well, let's see what notes are in there. Let's see what is the physician documenting about when they come in and complain about that low back pain. When you start taking a look at the visits they've had and where they have seen providers and what sites of care they've been in, you can begin to create a hypothetical picture of what's going on with this patient, and you can see whether or not there's something that you can impact. Right. And so that's sort of how this works, right? Low back pain is one example. A common thing ACOs will look for are your highest utilizers. So who's in the hospital the most, who's using the ED the most, who's got a lot of imaging claims, and then take a look at the highest complexity diagnoses and start to pull out who's impactable. And when you look at the journey, you can see through a combination of, they've been to the ER 3 times, what has been documented in, the subjective section. What are we saying? Or if there's a population health tool, is there a nurse care manager trying to work with them on that social determinant of health issue that could be the reason that they keep being hospitalized? Like a classic example is someone with COPD who keeps losing electricity, and so they have no oxygen. So they keep presenting to the hospital. Nothing the hospital is going to do anything if they don't have electricity for their oxygen, right? And so just kind of that's sort of where we might take something like, what does data look like? Taking the historical claims, which when you sign up for an ACO, you're going to be given data, and then analyzing that data and then marrying that with what do we find in the EHRs.
I'll ask this to Jonathan and Cody too. Looking into the Blue Cross Blue Shield official website, there's a nice blog post. What happens when your doctor recommends physical therapy? So I already have a problem with that label because your doctor recommending physical therapy means that you have to, you are an extension of a valid service. So it has to be the doctor that recommends physical therapy, where you all guys are doctors of physical therapy. You are a doctor in profession. So it's almost diminishes the value of your expertise and your experience. And then there's an entire narrative of what physical therapy is, which is essentially it's a course of treatment depending on your injury when you are not eligible for surgery and you cannot self-manage. So you almost have to then wait for the injury to occur for physical therapy to be a viable option. And I think first with Jonathan, how do you frame communication and how do you frame a conversation with a physician or an ACO group to say that if you're waiting for the injury to occur, you're already working retroactively? And what Dana was referring to, which is retroactive data, emergency room, the ED utilization, clinical utilization, healthcare utilization data is all retroactive data, which we're managing as post factum. It's like trying to appreciate yesterday's dinner, right? Like it was good, but what's on the plate today? How do you then create a framework for physical therapy to be a proactive modality and discipline that you don't need to refer to me? You need to trust my expertise that your MSK patient will receive comprehensive assessment and I will know which path to pick for this patient. I will know whether to send it to a physician, to a specialist, or throw them back to the emergency department. Jonathan, to you, what do you think is the right framework for these individuals to communicate with?
Alex, I like that you always ask the easy questions. I appreciate that. So I think a lot of that, again, it comes from the relationship building, because where we make the most progress is with the physicians that, in my opinion, seem to demonstrate the most humility. And I think a lot of times we give these physicians a bad rap because we just, like, we make a lot of assumptions, right? We don't assume good intentions. And a lot of what we perceive as this arrogance or this lack of willingness to collaborate is, I feel like, almost a defense mechanism for they're painted as the person that has to know everything in healthcare. And so they're not willing to let their guard down sometimes to admit that, like, maybe I don't know everything about MSK treatment. So when they trust you, though, and they know that you're going to take care of the patient, then they can let their guard down a bit. And we've seen this. I have two physicians in mind that are both very, very good physicians and are people that I would recommend, like, all my family go see. And they're some of the only ones I know that are willing to say, I don't really know what to do with this MSK issue. Like, I medically manage this thing, or I'm a pain management physician, so I'm more like, when nothing else works, that's when I help you. But I know a guy. And so they're willing to sort of defer to the experts, and that only happened through a lot of relationship building. And so, like, recently I had the opportunity to go speak with our ACO participants. So I got invited to go speak with the chairwoman, and so she and I are, like, side by side, giving a presentation, which was a super cool opportunity. And the thing we kept circling back to, and she and I both said, was, as a PT, like, I don't want to medically manage a patient. That's not my role. I don't want to do that. But you can trust me to be the expert in MSK care. So whether you send them to me or they come to us first through direct access, our job is going to be figuring out, how do we help? But just as importantly, we're trained on what are we not really up for handling. And so if it's medical stuff, we need to get them plugged in with you. And so we're able to catch people that don't have PCPs or that might need to go to the ED. We can tease all that stuff out. So again, I think, like, you become a partner. You're not in competition with them. You're not trying to take over anything that they do. You are a teammate. You know, you're not an ancillary service, but you're a teammate to be able to help. First of all, I think offload some of what they have to do daily, but also they can trust you with the stuff that they don't get a lot of training in med school on MSK care, and it's not their role. So I think, again, it's just, you have to come from a place of, I'm your teammate, not your competition. I'm not competing with what you do. Let me help you with the stuff that you don't have time to do.
Yeah. Cody, what do you think?
Yeah, I would add too, I think, to clarify, when we say our ACO, we're kind of talking about the health system. We're not, like, contractually a part of it, but just trying to lay the groundwork of how we can become more, as a whole for PT and how we can impact them. But I think what you mentioned, as far as, like, currently we wait for an injury to happen, largely that's the fee for service model, because you don't go seek care if you're not injured or sick currently. But I think when you think more about the value-based care world and full capitation, and then having full risk and being able to spend those dollars on how, mostly save downstream costs, I think that's where you would see even bigger effect, as far as necessarily seeing PT first. And largely, I feel like that's due to kind of the fee-for-service world we're in currently, and maybe transitioning away from. But I think Jonathan, nailed it as far as relationships go, and building that bridge and educating. And I think it's really, how do you lead with value from our side, and not just give me more referrals, I need more patients, but what can we truly do for you and make your life better?
I think that's brilliant, right? Like, and you guys, I think if you can highlight probably the best thing you have done for both your community and also your discipline is that you have educated these groups about the value of physical therapy. So both you, Jonathan, and you, Cody, you are the agents of education, and I think all your efforts are educational in a sense, but I think it's also then practical because you're not just educating using like social media or you using LinkedIn or using podcasts to educate the public. You're actually out there speaking to people, and a lot of these transactions are relational. That is built on trust, right? So if an ACO administrator trusts Jonathan or trusts Cody, they're going to start to explore the actual factual use of physical therapy services, and that's how you lay the groundwork for continuation of this education. That, oh wow, physical therapy really is a discipline. Oh wow, physical therapists are doctorate level educated professionals. Oh wow, physical therapy can help a lot of these individuals without the need for higher cost modalities. So this question would be for I guess all four of us, but more for Dana. Who is the right organization to lay the groundwork for education on a federal system level? So because what Jonathan and Cody does is going to be brilliant, and it has been brilliant. And I really hope that the state of Alabama is going to become the first state to actually have this fundamental shift in the utilization of physical therapy. But then there's 49 other states that are going to be laggards, right? So who is responsible for this federal education?
Seriously. So, no, I mean, the problem is we're responsible for ourselves. And, this is really getting very philosophical here, but this, kind of goes to what has the profession prioritized over the years, and where do we all just have gaps in what we can see? I know I blame fee for service a lot, but most of the blame here is on fee for service, and especially in the Medicare population, right? Where I'm going to go too theoretical on Medicare and versus managed care and all these things. But in Medicare, right, like taxpayers are paying out of their paychecks into Medicare their whole life. So the public pays for Medicare and Medicare Advantage patients. And then that money is spent in a way that the providers spending it are trying to make money. So we're taking publicly collected money, and then we're saying, but we have a for-profit healthcare system and we make more money by doing more. The providers that provide upstream care are not reimbursed for a lot of the really high value communication and connection and collaboration and partnerships. So primary care docs, psychologists and mental health providers, physical and occupational therapists and speech therapists, social workers. These are the clinician and provider types that are doing some of the hardest work, which is trying to impart an interest in behavior change for patients who are used to a fee-for-service system, like Cody brought up before, where I go get care when I'm sick, and that is the only purpose. I mean, if you look at, the generations before us, what came before Gen X, like my father in the silent generation, he wouldn't go to a physician until he had pain or something that there was no way he could manage himself. Ironically, he's now part of an ACO and so is managed much better. But that's just because they joined an ACO, ironically, right? So those primary care providers that my father goes to in the silent generation, and he's in his 80s, they became part of this because they wanted to change the way they practice. So it's not like it has to be that we as a type of upstream provider, which we are, or first access provider, we have to decide we want to flex the value that we have. But then, if you go a level above that, we have to be aware of it. And when these programs, when we change how we pay providers, it's not directed at us. It's directed at physicians because we've set up this sort of patriarchy where physicians are at the top. But I think to Jonathan's really, really smart point there, it's not their fault. It's not physicians' fault that they don't understand what value we provide. They're just part of the same system that we all grew up in. So it's kind of like we have to, and this is kind of why Alex and I started this podcast to begin with, it's getting out the message has to happen somewhat organically by folks like us and our guests being interested in, we have so much value stuck in this profession that should be used and leveraged for the betterment of the population of the United States. It's not set up for us to be successful, in totality. But there are things we can do that start with basic knowledge of how these things work and why they're good, not perfect, but why they're good and positive and we should support them. And then realizing value-based care starts with relationships, communication, and changing the perception we all have of each other. Making assumptions is super dangerous. It keeps the status quo intact, and we can't survive, and patients shouldn't live and try to be healthy in the status quo in the United States. We're failing.
Yeah,
So
a
go ahead,
couple
Tom.
points real quick. I was thinking about one a line I like. I can't remember where I read it. I've shared it with Jonathan before, but it goes like, you're a function of the system you operate within. And so I think largely that's what we're talking about, right? Is the fee for service model, and it's transactional, and you do a service and you get paid for that service. But I think that's obviously where value-based care is differently. And another thing I wanted to point out before Jerry Durham comes for me is I want to make sure we bring it back to the patient, because that's really what it's all about. Right? I think we've talked about our relationships between each other and providers, and the reason we're doing that is not just for our gain or for the other person's gain. It's really about the patient, because when we improve our professional collaboration and communication, like you say all the time, Dana, you're able to get the right person in the right place at the right time. And so that's really what it's all about.
Yeah.
I can kind of dovetail off that as well. I think the best reward I saw early on in my career as a staff physical therapist was through building some of those relationships at a really complex patient from a chronic pain standpoint. And it just like, she just felt failed by the system. She didn't trust the system. And like, I'll be honest, like I like chronic pain. I do a lot with athletes. That's kind of my niche, but I'm not the smartest physical therapist in the state of Alabama, or sometimes even our clinic, unless Cody's off that day, then maybe. But the thing about her, like where she actually started getting better through like weeks of trying different stuff and load management and listening and behavior change, was when I told her one day, yeah, I was just talking to your physician about like some of the medications you mentioned, or these digestive issues that you've talked about, and trying to figure out if we need to pull some other teammates into this for those specialties. And she said, well, wait a minute. Like, y'all talked about me, like with each other? And I was like, well, yes, ma'am. Like, work through the case, because we're not making a lot of progress individually, but you're wanting to get better. And no joke, like the next week, her next visit, nothing had changed at that point, and the next visit she was better. And so it was just that feeling of like, the patients that's who benefits from this, and that's what everybody's saying here, but they're the ones that benefit when we do this the right way. And so I think that was my motivation and incentive to see that type of impact, and then how can we blow that up even bigger? If we get more people doing this, how many more people can we help?
Yeah, and I think helping, right, is such a loaded term. When you guys are interacting with patients, I think that there's in a moment help, and then if you look at the downstream effects, they're actually multipliers. So that same patient that you help by communicating, by being an agent of change, that's short-term help. But long-term help, that same individual may take more self-control, may create a point of agency where that he or she will go on better self-care. So there's an interesting parable, and I've probably used it before, and I'm sure heard this a million times before, but David Foster Wallace, right, that commencement speech in Kenyon College in 2005 about fish, right? So there are two young fish swimming along, and they happen to meet one older fish swimming their way, who nods to them and says, "Morning, boys, how's the water?" The two young fish swim on for a bit, and eventually one of them looks over at the other, goes, "What the hell is the water?" Right? So that is us in a nutshell too. So I think physical therapy and physicians and all of these closed ecosystems, we don't know what the water is because we've been in it for so long that we don't have a perception that there's a world outside of this water, right? Because we've been swimming, and the older fish understands, right? Like the older fish knows that there's a bigger world out there. I mean, he may not have the power of agency, but it's there. So I think it's you guys are creating this foundation for change, and then the physicians have to join, and unless the effort is collaborative. Now, if it's just going to be us PTs knocking on doors and asking, it's going to result in some change, but it's going to be mild. The physicians and the systems also need to understand that there's 200 professionals ready to take on some of the risk, ready to take on some of the responsibility, but how do we get there? And then the systems need to recognize, and Dana is prolific about speaking about this, that the system knows the value we provide, they just don't care. And so how do we make them care? Well, create financial incentives, and that's what what you, Cody, have been so good about, which is using technology, but also using data to show facts, right? Like the facts are better than subjective ambiguity. So I think the final question or the final point is for Cody and Jonathan, you have a successful model that you were able to play and to roll out in your system. How do you empower other clinicians who have the same framework, who have the same capacity for change? What would be the 3 things to do to start engaging with systems and start engaging with physicians?
Go ahead, Jonathan.
I think the most important is, if I had to pick one, is like, if you take nothing else away from anything I say, be fine with being told no or not getting a response when you try to build that relationship. And the way that I view it is, again, early on, one of the relationships I was able to build was we got a referral from a physician and a nurse practitioner out of our organization's emergency department. And it was for like a standard, like acute low back pain, which, number one, really cool on them to recognize this is a good candidate for PT. But I remember thinking, like, why doesn't this happen all the time? Like, why is this not standard practice? And so I reached out to them and got a response, but those weren't the only physicians I reached out to. So that relationship has built for a long time. And that nurse practitioner actually has an urgent care now with another physician, and they refer all their MSK stuff to us just because we've had a relationship for years. And those are the cool stories. But like what I didn't talk about today is all the times I've reached out to chiropractors and nurse practitioners and physicians and asked if I could come by and chat with them and what are their pain points, and heard nothing back. And like that happens, but I think you're no worse off. Like you're in the same boat as if you didn't ask. And so it's worth a shot. Like it's worth reaching out and trying to figure that out. And I don't know, Alex, if I have 3, but I think that the second most important is, and I think Dana talks about this a lot, but that the individual ownership we have to take over our profession. Like if you're going to sit back and wait on that physician to ask you to go to lunch, just continue practicing the way you always have and don't complain about it, because nothing's going to change. You have to be willing to make that first contact because they just don't know what they don't know. And it's nothing, that's no ill intent on their part, but frankly, they don't have time. And so you've got to be the one to reach out and say, here's where we help. Here's what I can do to make your life easier. And then just be okay if you don't get a response. Because if you try it enough times, I promise you somebody's going to say yes.
I agree 100%. I would add too, I think I've heard you say it, Alex, and then I was speaking with someone recently and they reiterated it. You kind of have 3 options with where you're at, whether that's your job, your system, or whatever. You can accept it, you can change it, or you can leave it. So if you don't like where you're at, you have to choose one of those 3. I think for our profession and for me and Jonathan, we want to change it, and we want to change where we're at and how we can improve it, how we can improve the care for patients, overall. And I think that's the big part there. And then 2, there's not a playbook, there's not a specific do X, Y, Z, and you're going to get this outcome. We only started this just from learning from y'all, from learning from you, Dana, from, going down rabbit holes and just being curious about what all this means and how we can apply it. And then taking the theory and taking the learnings and then just trying to put that into practice and then see where it goes. Because like Jonathan said, reaching out, you may get a no, you may get a yes, but you're not better. You're not worse off if you get a no. I don't think you're going to be worse off if you try to initiate some of this or do what you can from your perspective and stop waiting for change from someone up above.
I love that, guys. You really are amazingly taking away so much and applying it. So taking the theory and putting it right into practice. Jonathan, you had said that the incentive, what's really the incentive for PTs to learn the value-based care world, even if we're not in risk models, right? Even if as of right this moment, as we're building and growing and sort of changing the perception of the profession, what should be the incentive? How should we think about this? One of the things that you said was you become the go-to clinic. So can you just talk a little bit more about that? Because I think if we can give some tangible, even though they're kind of softer things, some tangible, like how can this benefit me in this year, for example, even if I'm not taking financial risk and I'm going to see a check at the end of the year, what day to day, month to month is going to benefit me or my clinic?
Sure. So we spent a lot of time talking about, I think, what the difficulties are when you're trying to go get provider partners, get providers to trust you. But I will say from my perspective, as a clinic manager, one of the hardest challenges I face is how do you convince your team to do a little more work, is what it seems, when you're not going to be paid any more money than the person who's not. Like, what's the incentive there? And we have a really relational crew. We tend to care a lot about each other in this building. And so for us, a lot of times we get a student that we really, really liked, was a great fit, but like, sorry, we don't have enough volume to bring this person on. Or, this person really wants to work here, but we don't have a spot because we just don't have more volume right now. We're kind of maxed out. So I think when you can position yourself as you're speaking the same language as these providers who are in these ACO agreements, you understand whether you're necessarily contributing directly to their bottom line or receiving any of that money at the end. When you understand what their mission is and what they care about, and you can speak the same language, they're going to trust you more than anybody else, and they're going to send you all those patients, and I've never gone and said, hey, send us more referrals. But we start getting more because we understand what they need from us and how to help them. So all of a sudden now we're the go-to clinic for XYZ provider because they know we're going to deliver a product that is consistent, that they can trust, and that ultimately is best for the patient. And then, on our side, then what happens, a benefit for us is now we're busier. Now we have more volume. So now we need more people. So all these people we care about and want to be part of our team, we can support those people and bring them on and create these positions. And we've seen that play out a couple times.
And I would say that just to kind of take it one step further, you may have to point this out to the powers that be that care about this. But in the short term, it might be that you're improving the fee-for-service utilization of physical therapy, having your department become a larger source of revenue. So you're demonstrating, right, to the system or whoever the owner is, or whatever the setup is, that you can bring in more revenue. That's what we want in the primary care type providers. We want a system where more good work is being done by physical therapists and PCPs and mental health providers. And why is that good? Because it's going to reduce, by nature, because we're doing more upstream and we're engaging people and all the things we talked about, they're less likely to use the ER as a source of care, or specialists that you don't collaborate with, that we don't know, like the type of care that they provide. They're less likely to go off and find somebody to order imaging. So it's really good for your department to be doing that first even on the fee-for-service side. We want that. That's the fee-for-service that's good. We may not have all the billing codes that we should have. That's another story. But if you to your point, you're doing more work, you're getting more patients. Well, I'm sure your system would rather see them with you than with an outside organization. That's right. Everyone would like to keep it internal. But then you're also helping the ACO, for example, who's trying to avoid a lot of that, downstream utilization. So, but you may have to point that out. In the beginning, it's, we're able to offer more, provide access, and we're building this relationship. What's resonating when you talk about that, Jonathan, is, practices hire salespeople to go to physician practices and build relationships. They're not doing anything different, really, than you're doing. You're trying to develop organic communication and trust building, because people change behavior because they want to do something different. Change is really hard. So if you're expecting a change in how a provider that maybe in your community talks to their patients about therapy, or how much effort they put into sending them to you, that's going to come because of a relationship. And salespeople know this. You're just cutting out the salesperson and you're just building the relationship. It's a good thing. It's positive, right?
So to be an optimist and to give you guys more of an aura of optimism, 1902, Simon Newcomb was a Johns Hopkins University professor, a world scholar on flying machines and all things flying. So in 1902, he came out with a statement that flying machines, flight by machines heavier than air is unpractical and insignificant and utterly impossible. So he was famous for saying that humans will never take flight in machines. It's impossible. It will just never happen. And in 1903, Wright brothers took on flight. We need to get out of that structure and philosophy of containment. And what you guys are doing is fundamentally what we need to do as an industry as a whole, is that we can't foresee the future unless we fantasize about the future that is positive and optimistic. And also, the change is never linear; it's curvilinear, right? So you guys putting the light in the fire is passion that lights the fire, but it's perseverance that keeps the fire going. So you can keep the fire going by just continuing to knock on the doors, but part of it is just having the right mission and the right purpose, and being okay with not getting success right away. But when the success starts to occur, like in your case, it's actually going to be more of an exponential growth of success. So hopefully more clinicians will get to that point too. So thank both of you for doing this.
I just say thanks again for having us on, and it's always great talking with y'all. And I know me and Jonathan have both learned so much from both of you, and all the resources you put out and all the research you share, Alex. And I think I've learned more about policy in the past probably week than I have my entire life just from reading things you post, Dana, and have shared. So thank y'all for all the work y'all are doing, and really appreciate what y'all do.
Yeah, definitely. I would echo that entirely. I think that all the relationships are great, but if you don't know how to leverage those into something bigger, they're not as helpful. So I appreciate everything that the both of you put out, and like Cody said, the resources out there, the guests that you have on, just have furthered my leadership ability, networking, understanding of policy. We got a long way to go, but I just appreciate everything that both of you do to put out there and help us out that are trying to be a little better and a little less dumb every day.
We need more of you is what we need. We can talk and you guys are carrying it and practicing. Thank you for sharing your experiences with us. Thanks to Cody and Jonathan for joining us today and proving that value-based thinking creates value today, not someday. If you're walking away from this episode with one thing, let it be this. You don't need permission to start changing your practice. You don't need a risk contract to build provider relationships, and you don't need a perfect playbook to take the first step. What you do need is to make a choice, accept the status quo, change it or leave it, but you do have to pick one. Remember what Alex shared, the experts declaring something impossible are often closest to being proven wrong. That Simon Newcomb declared flight impossible in 1902, 1 year before the Wright brothers took off. Your impossible might be closer than you think. If this conversation sparked something in you, don't let it fade. Pick one provider relationship to deepen this quarter. Learn what your local ACOs measure. Start building your own proof of concept. Passion lights the fire. Perseverance keeps it going. And we will see you in the next episode. Until then, keep building the future you want to practice. Please like, subscribe, and share our content with your friends.